Welcome to Collab.Conversations, the podcast where impactful discussions serve as catalysts for change. I'm your host, Sabrina Hanna, and this podcast is dedicated to advocacy and the individuals driving positive transformations in the Canadian healthcare landscape. And as International Women's Day is approaching, I really wanted the focus of today's conversation to be on women's health. And I have with me bukun adegbembo and Rebecca Armstrong from the Canadian Breast Cancer Network. Hi, bukun Rebecca. Thank you for being here today.
Thank you for having us.
My pleasure. Just before getting on, I was looking at the CBCN website, and I found the history part of CBCN really interesting. Can you tell me a little bit about that?
Yeah, we're actually going into our 30th year in operation, and it started, I think, from like a conference where they wanted to ensure that there was the patient voice kind of at the heart of decisions. And yeah, they wanted to make sure that the networking between, we have a large country, and to make sure that every single person is across the country being heard. But I think from that national conversation is what kind of drove the idea behind CBCN in terms of ensuring that we have that, national network, and that patient breast cancer care across the country is equitable.
Yeah. And so what I was reading on the website is that it was, I think, a House of Commons conversation that happened. And so and the need for a national patient-directed group. So I found that really fascinating because normally it's a patient who's been diagnosed and is online looking for information, can't find anything, and then decides to start an association or a group. Whereas with CBCN, it's like the government said this needs to happen.
Yeah. And we are also just in a very unique position where our board have all been affected in some way by breast cancer. So they've all had a breast cancer diagnosis, or we have a new board member who has BRCA. So she is sort of a previvor, as they call it. So that is sort of the driving force behind our organization, is to make sure that that patient voice is what is directing the work that we do.
Yeah. And so how did both of you get involved with CBCN?
I've actually been with CBCN for a little over a decade now.
Oh, wow. Yeah. Congratulations.
Thank you. Give or take a few maternity leaves in there. But primarily my role has always been sort of focusing on the education and information aspect of the work that we do. So I started out with coordinating our in-person events, and then that sort of evolved over time to a little bit more virtual, and I was in charge of developing and updating our resources and our website and our blog, and I've really had that sort of educational focus. My personal reason for getting involved with CBCN was that my mom had a breast cancer diagnosis when I was 19, and that sort of I was young. I was a young woman, and I did not handle the situation very well, I would say. And I wanted to be able to help women a little bit differently than how I sort of approached it with my mother. I wanted to make sure that I was prepared for, if she were ever to have a rediagnosis, or if it were a recurrence, and to help other women who were in that situation as well. And that's sort of my personal kind of goal with being at CBCN, I guess.
For myself, so I got started with the organization in 2018. So they had done a report on kind of like the lived experiences that women were having after being diagnosed with breast cancer. And so the organization was looking to do an update on that, but specifically for the financial impacts of a breast cancer diagnosis. So during the summer when I was in grad school, I kind of was hired to kind of lead that research project. And then in 2020, so that was Rebecca's first maternity leave. So I was hired to kind of cover that position. So again, as you said, like a lot of the communications and patient education, social media, website management. So I did that. And of course, a few months later, that was when the pandemic happened. So everything got switched virtually, and I had to really take on a lot more and kind of learn the job without being able to kind of work in person with my colleagues. And then, so I've just been with the organization ever since, and then the roles have kind of expanded. So Rebecca's taken fully more of the patient education. We've hired someone else that does more of that communications and social media piece. And so my role at the organization is the operation, so kind of managing stakeholder relations, a little bit of fundraising, and just making sure that everything is running smoothly with the organization.
Yeah. And do you mind if I ask what you said you were in grad school? What were you
Yes.
studying? If you don't
have,
mind me asking.
no worries. I have a master's in social psychology.
Yeah.
Yes.
All
So
right,
unrelated to the job, but
Yes, it's a little bit more
yes.
related than my degree.
Yeah, so I guess it comes into play, especially with the education piece in terms of, you know, that psychosocial aspect of, you know, getting diagnosed with a breast cancer, you know, with breast cancer. So it kind of plays a role in that way, and just knowing that just because you're diagnosed with breast cancer, it's not just impacting the health, but there's other impacts on it. And, you know, I can use that to kind of drive some of the sessions that we do, you know, whether it's on mental health or calling for better and equitable research and clinical trials and things like that.
Yeah. Well, speaking of equitable research, let's like I have been looking forward to this discussion for a really long time. And like I just told you guys before getting on camera that I've been speaking to a lot of women diagnosed with cancer this week because it's going to be International Women's Day on Friday. And as a woman, and I'm sure, you know, like the same for you, like you understand, and it doesn't matter if you don't have a cancer diagnosis, you understand the challenges of going through the healthcare system. So I'm just going to jump right into it. Can you talk to me a little bit about some of the factors contributing to disparities in cancer outcomes among women?
Yeah, I think the big ones are obviously race and ethnicity and age, specifically for breast cancer, and income. Um, I know there's, you know, everybody has their unique story to tell when they're diagnosed with breast cancer, and those factors contribute to how they experience that diagnosis and how they work through the healthcare system. Particularly, you know, if you are an immigrant women or Inuit women, um, you may not have the same comfort in terms of speaking about intimate health issues. If you come from different cultures, you don't have those there's sort of a stigma around intimate health issues, and breast cancer is one of those intimate health issues that people don't really discuss, and so the awareness is not necessarily there. There's also you know, a lot of our research really focuses on the outcomes and how it affects like white populations, and it doesn't necessarily look at other populations.
Mhm.
We know that BRCA1 and 2 can affect Ashkenazi Jewish populations, but we have no idea if there are other races that might be more predisposed to certain mutations or things like that. And we know that Black women and Hispanic women have a higher rate of triple negative breast cancer. We don't really know exactly why that is.
Yeah, that's really interesting. And actually, this week they've been talking about that a lot. And I think it was because there was some US-based data that was published on race-based data as specific to breast cancer. And they were talking about the incident, I guess not only the incidence of breast cancer in Black women, but the increased mortality of Black women with breast cancer. And I think this is probably true for Canada as well. And the other thing that I found really interesting when they were talking about it is that, and actually it was a Canadian doctor who was talking about it on the news this morning, is that a lot of the Black women are not even told about the genomic testing or the genomic profiling in breast cancer. And so, I mean, I'm trying to wrap my head around it. It's already difficult to be a woman. It's even more difficult to be a woman of color. And so, like, when you're going to the hospital and or your doctor, it's already difficult to get the diagnosis. Women are more likely to be diagnosed later than men across all cancers. Like, why is this happening?
I think there's probably like a lot of different factors in there. So like Rebecca had brought up, there's like that cultural aspect as well. So there's like the awareness piece. So if you don't know kind of like about breast cancer, about the different types of breast cancer, genomic and genetic testing, you don't know the questions to ask if you don't know that these things exist. So there's that piece. But I mean, like,
There's
medical
also
racism, like
yeah.
there's that too. Like if you're also like, approaching, people from different cultural backgrounds, you might not, and this isn't saying that this is what all doctors are doing, but it is shown that things like this exist where they might not bring up these topics with patients. And so if the patient isn't asking, the doctor isn't telling, then they kind of get left in those gaps. So then they get diagnosed later, or they might not know certain symptoms that are, that these symptoms are related to breast cancer. So they might not follow up with it. You're going to say?
Well, and also age is another factor that works into that as well. If a woman is younger being diagnosed with breast cancer, they tend to have a harder fight in getting that diagnosis because people are like, you're too young for breast cancer. That's not it. That's like, don't worry, don't you're overthinking it. It's not breast cancer. And then so if they have a harder fight getting that diagnosis, it takes longer, and then they are diagnosed at later stages as well, which means your cancer is harder to treat, essentially.
Yeah. So if you just imagine that it's kind of similar across the board in terms of like if it's a person of color, if it's an immigrant, if it's someone in like an Aboriginal population, it's just a combination of like the awareness, lack of advocacy, and then other things coming into play from the actual healthcare system as well.
Yeah, and so you're seeing that in your breast cancer population, but I imagine that that would be true across all different tumor sites.
Yes, we would imagine so.
Yeah, and so there was also and I don't know if it was like published data, but the face of cancer is changing. And so like we're thinking of cancer as a disease of the aging, but what we're actually seeing now is that cancer is becoming more and more prevalent in the under 50 population. I think this is true. This is especially true in breast cancer. I mean, it's true in all the different cancers, but can we talk a little bit about that, about the experience of younger women with breast cancer?
Yeah, I think younger women have different needs that play into their experience going through that treatment. Specifically if they have families. I know that I have a young family, and when I get a cold, it's like I still got to do my life. I still gotta, take care of the kids and get them, ready for daycare in the morning and do and women are often that default parent in that role. And so when they have, a breast cancer diagnosis, something that's more serious, it can affect all different aspects of their life. And there's a certain level of guilt, there's a certain level of overwhelm, there's that notion of going from the caregiver to the care receiver, that really factors into how a woman with a family can be affected by that. They might have, older parents who they're also taking care of at the same time. So they have kind of that sandwich of people who are older and younger who are dependent on them. And single women don't necessarily have the support of a spouse or a second income to be able to help them through that diagnosis. So there's that as well, that can factor into a younger woman's diagnosis. But yeah,
Yeah, there's also like the career as well. So if they're kind of early on in the career, it can really impact, their ability to like maybe grow in their wherever they're working, if they have to take time off work, or if the EI they're getting is not enough. And so that's actually something that we're addressing. So Rebecca could speak about our Never Too Young booklet that we're putting together.
Yeah, we've had a Never Too Young kind of newly diagnosed guide for many years now. And we are in the process of updating that to make it more, a little bit more modern and a little bit more timely to young women today. And that will be released this year. I'm very excited about that. It will be really helpful for women. And it focuses on kind of all of those psychosocial impacts of a breast cancer diagnosis, from families to being single to having a career to fertility preservation, and it focuses on all of those aspects that come into play when a young woman is diagnosed with breast cancer.
Yeah, and those are all things that young women need to take into consideration when they're being diagnosed with cancer. Like especially the fertility preservation. And I know when I was working in melanoma, we were seeing a lot of younger women being diagnosed in that space, and like nobody ever asked them. And I just have a friend who had some precancerous cells in her uterus detected, and so for her they needed to remove her uterus, but nobody asked her, are you like, were you planning on having a family? How do you feel about that? So it's really
That's tough. It's not fair.
Yeah.
that kind of option gets taken away from a woman without even the discussion.
Yeah.
I think that plays in. Oh, I was just gonna say, I think that also plays into that awareness piece again, because again, if you don't know that these options are available to you, you're not gonna, ask the healthcare provider. So once they say, "Oh, this is, the treatment that you have to do," they're not gonna say, "Okay, how is this gonna impact, my family planning or anything like that?" They're just gonna say, "Well, the doctor said that this is the treatment plan I have to go on, so this is what I have to do. This is part of the impact of being diagnosed with, breast cancer or ovarian cancer or anything like that. It's like, oh, this is just part of what comes with the diagnosis. But there are options, there are different things that women can look into.
Well, and what's additionally something that, we also need to consider is that women on average get paid less than men. So our income is affected as well when we have a breast cancer diagnosis. Everybody knows that. And if you have a lower income, or you don't have a job that necessarily can afford you to take the time off to be able to have the treatments that you want, to have fertility preservation, or to get the mastectomy or the lumpectomy over the mastectomy, if there is a longer treatment plan involved, you might not be able to actually have that. It's almost like sometimes it's a choice that you need to make, but it can be almost a false choice sometimes because they don't really have that ability to take that time to do it. I had heard of a woman who was a server in a restaurant, and her doctor told her, you need to have a lumpectomy. That's going to be followed by radiation. And it was actually my mom who was talking to her, and she was like, well, you do have an option. You can have a mastectomy, and that's you don't need to have the radiation if you have mastectomy. And she ended up choosing that because she's like, I can't afford to take the time to have the radiation. I need to get back to work. Like, that's not something. So it was the awareness piece that she didn't know that she had that option. And then it was almost like a false choice when she realized she had that option, because it was like, well, I can't do it anyways. I have to go with the shorter one, because and the more invasive and the more and what does that look like then for reconstruction options? It's not necessarily equitable, because she doesn't have the income to be able to afford to do that.
Yeah, I mean, that's such an interesting point to bring up. So what is CBCN? I mean, it really shouldn't be up to any of the advocacy groups to be talking to patients and saying, well, that is not your only option. You do have only options. But how do we address that? And maybe not just the CBCN, but as a healthcare ecosystem, how do we address that?
I mean, I think we need to start in terms of data collection and just ensuring that our research is equitable. It is representative of the population. If we're not collecting the data to see where those needs are, then we're not going to know where those needs are. And everything is mostly just anecdotal.
Yeah.
And then from there, we also need to know how our treatments are affecting different populations. If our research is only looking at a specific population, we don't know if drug therapies are going to affect different populations in different ways. And so that is overall what really needs to happen. In terms of what CBCN is doing, we are trying to make that awareness more known. We want to ensure that women know what their options are, know where they can find financial support. We have a financial navigator database that helps with that. And we want to, I think overall, we also need to prioritize the mental and social aspects of a cancer diagnosis. That is inequitable across the country. You hear women, talk about how they get a diagnosis, and then they are not necessarily aware that they can go to a social worker in the cancer center, or they can go to, some cancer centers have patient navigators, but that's not equal across the country either. So there's those differences based on, it's not even just where you live, it's what hospital you went to. If you are rural, you have to travel for your treatment, which adds another enormous burden onto your treatments, which is a tough thing to have to accommodate. And so how can Canada make that easier on those rural communities? And we also want to make sure that we can just champion that voice and just hear what women are saying is key as well.
And I think an important part of the research aspect is that race-based data. So it's something that Canada isn't really collecting. So there's like a lot of limitations, because then we end up relying on, data from like the States and all of that, which we can, infer that it might be comparable, but it's better to have our own data. Yeah, based on Canadians, because we have a different population, we have a different history, we have different numbers of immigrants. So it's important for us to collect our own data to see like what is actually happening in Canada, so we can rely on that. Like, for example, even the stats about like Black women and Hispanic women having higher rates of triple negative breast cancer. Those are statistics that we're relying on from the States. So we can say, yes, it might be the same here, because we are seeing higher rates of triple negative breast cancer in Black women in Canada, but we don't know what the actual number is. We don't know if it's between 10 to 20%, or if it's higher or lower, or if there are other types of breast cancer that are, higher in certain populations. So part of that is, pushing for research to be more equitable and have, collect race-based data. CBCN isn't specifically in that research space, but it is something that we, advocate for through other groups that we're connected with, and just, any inputs that we give to the government in terms of just, that equity piece, and making sure that there's proper representation. Again, as Rebecca said, not just based on where someone lives, but also like who the person is.
Yeah, and I think like it goes even beyond the race-based data, and it needs to be gender-based data or sex-based data. And I think, like we don't have that in oncology at all. And I mean, I don't know if you can answer this question, but a lot of the research done in across I was gonna say across all diseases, but all the predominantly all the research that is done. And if you've watched a podcast or you've watched me, you've heard me talk about it, or we've had a conversation, you're going to be tired of listening to me say this. But a lot of the research is done on male cells, on male mice, and in clinical trials on men. So like, how do we get to the point? So it's been studied that there are, because we know that the women's immune systems work differently than men, women's brains work differently than men, our pain receptors work differently than men. And so when we're developing drugs for men, then obviously it's not going to work as well in women. So how do we get, especially like in a space for like breast cancer where it's a predominantly female disease, although it can happen in men, much more rare. How do we get to the point where, and I don't know if this is already happening, but is the bench side clinical research happening specifically in women? And, but is that bench side research happening in women? And then how do you disaggregate that data so that it is super sex differentiated? And
I
that could
think
be like a really technical question you don't need to answer, but
well, I think for us specifically, like because we're not in that research space, we don't know kind of that background in terms of like research being, sex or gender based. For us, I think it's more of that equity piece. So making sure that there's diverse populations joining clinical trials, and even without getting into diverse populations, just individuals joining clinical trials. Like a lot of people don't join them, whether it's because of lack of awareness or if it's fear, or if they're just like, well, this is the standard of care, so I'm just going to go with it. Like, why sign up for a clinical trial? So I think for CBC and our piece is more, again, that awareness of letting patients know that there's certain, clinical trials that they can join. And then also championing for having diverse populations. So that would come from like the researcher side in terms of like when they reach out to patients to join, their clinical trials, or when they're selecting centers to have their clinical trials, be more aware of like, you can't always go to like the big centers in like Toronto, for example. You're going to keep getting the same populations joining, and, look into like the rural cancer centers or community centers and try and like make sure that that diversity is built in. And it goes back to what Rebecca said earlier in terms of like, by doing that, then we make sure that the research and the drugs that are being developed are based on diverse populations rather than just like that same population. So I think that's, for us, that's kind of more the piece in terms of like making sure that the clinical trials are based on different populations, so that the drugs, because they're going to be used in different populations. So yeah, we can't really speak, or at least I can't really speak to that gender piece. But Rebecca can also speak more about what we're doing in terms of raising awareness about clinical trials among breast cancer patients.
Yeah, we are. We try to make sure that the research that's being done is translated in a way that's understandable for patients, so they know what's coming out. And we do that when we attend the conferences. We put out specific information about what those research highlights were, and we also do regular webinars across the year on specific topics where we have an oncologist who speaks on what those advancements are. And we've been lucky to find oncologists who are really, really good at speaking at a level that patients can understand, which is amazing. And we also are looking to put out more information about what the open clinical trials are in the country. And we'll be doing that sort of routinely throughout the year to make sure that those open clinical trials are at least being brought to the attention of patients within our network as well.
A lot of times patients think that, if there's a clinical trial that they're eligible for, their oncologist will be the one to tell them, which yes, in some cases it does happen. But that might be like, maybe like oncologist is part of the study, so that's why they know about it, right? So if it's a bigger center, it might be harder as well. Oncologists might not know about every single trial that's, open and recruiting. So patients can't only rely on their oncologist to tell them what's available. So we're hoping that by sharing that information, patients are like, aware of it. So they might see it and say, oh, I fit this out, I fit this criteria. Let me look into this more. Then they can discuss it with their oncologist, who can give them more specific information of like, yes, you can join this, and, get them set up with it and all of that.
Or even if they're in a larger city center where a clinical trial might be happening at one hospital, but not at their hospital, they might not be talking to each other.
Yeah.
And this is, and my next point is purely anecdotal for me doing the research on what open clinical trials are available. They are happening at those larger hospitals. They're not necessarily happening at the smaller hospitals. A few of them were even saying that they were taken off when I did see, smaller hospitals and smaller communities, they were actually pulled for some, and I don't know what the reason is. And again, that's purely just me seeing that as I was doing the research. And it struck out to me because it was like you said, in terms of like the rural versus the urban, those rural communities might not be getting access to those clinical trials in the same way as well.
And they might be pulling it because like people aren't signing up for it. So it's like, oh, there's low recruitment. So it's kind of like this cycle.
This vicious cycle,
like, if you prioritize having diverse populations, then you have to keep those open, even if it's going to be, a lower populations that are signing up for it, or maybe find somewhere that's, kind of in the middle, so that people that are in smaller communities or diverse populations can still have access to these centers and access to these clinical trials. But I think if they're prioritizing it, they'll be able to find a way to say, okay, let's make sure that we're getting different people signing up for this, whether it's, I don't know if these are possible, but, helping with traveling and getting there and out of pocket expenses or things like that. Basically just make it easier for the patients.
And also just really trying to destigmatize the fear around clinical trials as well, because people hear of a clinical trial and they're like, well, no, I want to stick to what's known. I don't want to go into any kind of, and so if we kind of reduce that fear, then people who maybe are already fearful of the cancer system, and that could be because of, cultural reasons where they are not comfortable talking about these intimate issues, that might also play into their kind of comfort in joining those clinical trials as well.
Yeah, well, I think also that, we have to be realistic that in Canada, there's not a lot of phase 1 clinical trials happening, and it's, mostly phase 2, rarely now phase 3, because that's just the way the science is going. And so it's not really experimental anymore.
No.
You're not in that phase, and it's like
and people don't know that.
Right. And now clinical trials are really like standard of care. And if you want to get like best quality care, then the clinical trial is normally the option if it's available to you.
Absolutely.
Is that something that CBCN does? Do you help patients find clinical trials?
Well, we do it more of a broad-based basis where we are putting out information about clinical trials that are available in Canada. If a patient were to come to us, we do also do, individual patient navigation. So if they want to know how they can get access to certain treatments, or if they are, sort of reaching the limit of exhausting their treatment options in the metastatic setting, then we can help them try to find what they could access from a clinical trial perspective.
Yeah. So there's a couple of things you said like earlier in our conversation that I want to get to, but you keep saying things that I want to touch on now. So I'm going to go with the metastatic because I feel like because there is so much conversation around breast cancer. Everybody knows about breast cancer and all the fundraising in October. But I think what people don't generally understand is that it's great if you get breast cancer and it's caught in an earlier stage, but if you're in the metastatic stage, it's not as, pretty and rosy as the commercials make it seem.
Mm-hmm. Yeah, it's funny because not funny, haha, but funny kind of like intriguing, because when I first started at CBCN, metastatic breast cancer was not talked about. So I would say we have come an enormously long way in terms of getting that topic as a focus in the breast cancer community. And it still is something that we need to work on to get it in the general population awareness. And that's something that we just continue to do, and making sure that the information that we're sharing is also equitable between early and metastatic patients, and that we're sharing information that is just sensitive to their needs, essentially changing that language around, saying breast cancer survivors to people living with breast cancer is those minute details are important, but it's also ensuring that women have access to the treatments that they need in the metastatic setting, and ensuring that they have the support that they need. And I have seen a huge difference within the breast cancer community about talking about that metastatic stage. And it's gone, and it's amazing to see the progress we've made in the last 10 years. But there's obviously still progress that continues, especially in that general population setting.
Especially with like the pain, or saying like, I can't wait to ring the bell. Some women will not have that chance. So it's important to be able to highlight that there are different stages, just like there's different types and subtypes of breast cancer. There's also different stages of breast cancer, and depending on which stage someone's diagnosed with, it's can be a completely different disease and experience. So just making sure that in all the work that we're doing, not only as we're putting information out there, making sure that we're pinning out information for metastatic breast cancer, but also the voices that we're sharing, like making sure that women diagnosed in that stage, their voices are also being shared, so that there's changing the language of like using survivor, or showing that breast cancer isn't a pink disease or things like that.
That's why CBCN is predominantly blue, because we want to make sure that it's not just all like
pretty
pink ribbons. Yeah. And that is really what drives. That was a big, I remember years ago, we did kind of a little bit of a rebrand, a refresh on our logo and our imaging and our website. And that was like the core thing that our board of directors, who are all breast cancer patients, said. They're like, it can't be pink. Like we need to keep it with that. There needs to be blue in there, because we want to make sure that it is representative of all stages of breast cancer.
Yeah. And so just going back to the comment that you made earlier, you didn't have time to be sick. You have a young family you need to take care of. And do you think that this is like a societal belief, especially I think in women, is that, we have families to take care of, we have older parents we need to take care of, we have a job to go to, we have to cook dinner, we have to do the laundry, we have like so many things to do, we don't have time. And so like we're not feeling well and we just continue to push it aside.
Yeah, I actually have a very personal story related to that. When my mom was diagnosed with breast cancer, it was at a time where my dad, who has just a whole host of health issues, it's just he's the sick one in our family. He's always been sick. My mom's always been his caregiver. And then she got diagnosed with breast cancer. She had kids, she had a job, she had a sick husband, and she was diagnosed. 3 weeks later, she had a mastectomy. And then that was it. She pivoted right back to where she needed to focus. And it took maybe a year or two once my dad's health issues sort of settled to be like, whoa, what did I just go through? And she just completely shoved her entire feelings and emotions and that whole experience aside so she could focus on the rest of her life because she didn't have time to do it. And it had really long impacts on her mental health going forward. She still talks about it today as something that's like, I didn't get a chance to like really process that part of me. And that is something that, you know, I think we hear a lot about with women. There was just a patient story that I've read that will be on the blog soon, about a woman who she was a young girl when her mom was diagnosed with a different type of cancer and passed away at a young age. And then when she was diagnosed with breast cancer, she needed to do everything she could to make sure that it didn't affect her child in the same way that it affected her. And so we put all of the needs of everybody else around us ahead of our own. And there was a really interesting analogy that someone had told me many years ago about how, you know, there's the cancer patient at the middle and they're the circle, and then there's another ring around them, and those are their, you know, kids and their spouse and their parents, and then there's a circle around them, and the circle keeps getting bigger and it gets extended. And the idea is that you look outwards for your support and that you shouldn't be looking inwards. And I was like, that does not relate to a woman in any way, shape, or form, because we don't have the ability to just not focus on the emotions of the people around us.
They're focusing on us.
Yeah,
Like,
yeah.
yeah.
Yeah. And it was really eye-opening because I was like, that's not what women can do if they have all of these other priorities.
Yeah, and it's, I mean, just going back to what you said about how you didn't react well to your mother's diagnosis. So it's like,
yeah.
yeah, go ahead.
No, that's true. I was another factor in that she needed to also be aware of my feelings. And so it's not just, you know, women with young children, it's women with all ages of children. That really affects, because they are always going to want to make sure that their kids are supported in that experience.
Yeah, it's interesting. You know, my mom had a benign brain tumor in her head. And for me, like in the space that I'm working, it was like there was no time to like think about how I felt about it. It was just like, okay, we got a surgery, we're gonna do this, we gotta do that. And it was like I know my sister might be a little bit upset with me saying this, but she won't listen to it anyway. Like my sister's a little bit more emotional than I am, and you know, my brother is a man and maybe less emotional, but definitely sensitive. He also is not going to listen, so it doesn't matter. So I felt like because I was the one with the information, like I needed to deal with it. I needed to be with her at the hospital. I needed to be at the doctor's appointments. And it's like I never actually really took the time to think about, you know, like I didn't feel anything. I just did it.
Pushed through in that kind of clinical, you put your working hat on and focused, you that kind of helped you cope through that, maybe.
Yeah, exactly. Interesting, like thinking of healthcare from a women's perspective, because I've had, like I told you guys earlier, I've talked to a few women and I've heard the same thing repeated, is that they felt dismissed, they felt brushed off, they felt, and these are women with cancer. And you know, in Michelle's experience, they told her she had 24 hours to live. And in Sarah's experience, she had a very rare cancer, but both, you know, they both felt dismissed. They both felt brushed off. They both felt like they weren't believed. They felt like they weren't heard. And it's like, it's already a complicated diagnosis. And then like just that extra layer makes it not complicated, but it's like an extra barrier that women have to go through.
And I think that's kind of one of our core values is making sure that we share information that can help a woman feel empowered to fight for her needs and to be part of that sort of shared decision making, because she is allowed to. It is her body, and she is allowed to have those opinions and those
Emotions.
and those decisions. She's allowed to make those decisions. She's allowed to be part of that conversation.
Yeah, I'm seeing that we're unfortunately coming up on time. There was more questions that I wanted to ask, but I want to ask you, so what do we need to do? And maybe this is something we need to do as patient advocates. What do we need to do to start shifting that conversation so that women are starting to feel heard? And so they're not being told they're overreacting or they're being emotional or they're being irrational, that they're really being heard in healthcare.
I think we just need to keep talking about it. Just keep talking about it. And it will help women understand that, we may all have unique experiences, but we all have that shared,
the specific experience of what you're talking about in terms of like feeling dismissed and all that. So the diagnosis or the disease might be different, across the spectrum, but we're still having those same experiences of like, being dismissed, if you want to call it sexism or anything. So yeah, just I think sharing other women's stories helps other women see like, okay, I'm not alone in this. There is actually something going on. It's not all in my head. It's not, I shouldn't feel dismissed about this. If other people are going through it, then clearly there's something there, that is happening. And I think also just like that raising awareness piece, empowering women to not only see that they're not alone in what they're going through, but to also empower them to speak up, to raise their voices and feel confident in doing so. Not feel like they're asking for too much, like it's your health. So you're never asking for too much. If you're asking for, equitable and the best health care that you can get, like you're never going to be asking for too much.
Mm-hmm. And we also, just to plug, we have like a patient Facebook group that can also help women, speak to other women and connect one-on-one to share their experiences. And it's a great way for them to be like, I'm experiencing this. Has anybody else experienced this? And it allows people to kind of collectively connect across the country to be able to ensure that they are advocating for themselves as well.
Yeah, and if you want to share the link to that Facebook group, I'll include it in the description for the show. And just going back to what you said about advocating and talking about it and raising the issues, I think what we saw happen during the pandemic is like people were actually talking about how the vaccine was affecting their menstrual cycles. And this actually prompted, I think it was the NIH, to do a study on women specifically, which, doesn't usually happen. So I think you're right. We do need to just keep raising awareness on the topic.
And it was also interesting that a little off topic, but breast milk was also creating antibodies for babies. I had a newborn, so I was like, oh, my baby's somewhat protected because if I get COVID, my breast milk is going to protect her. And so they also started doing studies on that to see why that was the case.
Oh, that's interesting.
I don't know what the outcomes were, but that was one of the things in the early COVID days that they were doing.
Yeah. Well, if anybody's interested, I did actually do a lot of research on how the vaccine affected menstrual cycles.
Oh, yeah.
And if you don't want it to affect your menstrual cycle, you actually have to take it while you're on your menstrual cycle.
Oh, that's good to know.
Yeah. So I don't know, like it was during the pandemic that I was doing all this research, and I don't know if it's been validated or not, but go do the research if you're interested.
That's interesting. Good to know.
Any final thoughts?
I think just keep sharing and advocating for, women and their health and Women should keep sharing their voices, whether it's through, within their communities, with their family and friends, connecting with the groups, patient groups, and sharing their voices that way, sharing their voice with policymakers. That also impacts like the policies and health reforms that are being made. Government relations does want to hear from patients and hear the patient voice and hear how different things that they're, putting through are affecting them. So I think it's important for policy to be based on the people that it's affecting. So just keep sharing your voices and, we'll keep raising awareness, and hopefully that leads to meaningful impacts and changes.
And specifically for CBCN, if there's patients listening or watching this, we have a whole host of really amazing resources on our website, and we also are always looking to work with patients, whether it's sharing their stories on our blog, whether it's being part of our advisory committees on our future resources. We are always looking to sort of expand that network and be able to have that voice be at the heart of everything we do.
Yeah, I was going to ask, if people wanted to connect with CBCN, where would they go? So to your website.
Yes. Yeah.
And
cbcn.ca.
Perfect. I'll also include a link.
Okay.
I think for me, the takeaway from our conversation is, and I don't remember which one of you said it, but I think it was you, Bukun. It's your health, and you're never going to be asking too much. So I think, if to everybody who's listening, just remember it's your health and you're never asking too much. So thank you, both of you, Bukun and Rebecca, for chatting with me today, for sharing your insights and your experiences with me. And to everybody who's listening or watching, not only it's your health, but remember to raise your voice, raise awareness, advocate for change, because it's not going to happen unless we ask for it. So until next time, stay informed and stay curious.